Chapter 29 of the Diabetes Canada 2018 Clinical Practice Guidelines is on chronic kidney disease and diabetes. My name is Alice Cheng, and I'm narrating this deck on behalf of the authors Phil McFarlane, David Cherney, Richard Gilbert, and Peter Sr. Key changes in this chapter include reinforcement of screening algorithm for CKD and diabetes, multifaceted cardiovascular risk reduction in people with diabetes and CKD, an update to the sick day medication list, and avoidance of combination of agents that block the renin-angiotensin-aldosterone system. The checklists for chronic kidney disease include screen with random urine albumin-creatinine ratio and serum creatinine for estimated glomerular filtration rate at diagnosis and then annually for type 2 diabetes. Diagnose with repeat confirmed ACR greater than or equal to 2 and or an eGFR less than 60. Delay the onset and or progression with glycemic and blood pressure control, as well as the use of ACE inhibitor or ARB. Prevent complications with dose adjustment, sick day management counseling, and referral when appropriate. Why is this chapter so important? This chapter is so important because people with diabetes are 6 to 12 times more likely to be hospitalized for CKD or end-stage renal disease compared to someone living without diabetes. These are data from Canada looking at prevalence rate ratios of various complications among hospitalized individuals aged 20 years and older based on diabetes status. So the rate ratio is comparing those with diabetes versus those without diabetes. And you can see that the presence of diabetes increases the risk of hospitalization for CKD or ESRD by a tremendously high fold. In addition, diabetes continues to be the #1 cause of new cases of end-stage renal disease in Canada. Therefore, it is important for us to understand what we can do to prevent the development of, as well as the progression of, CKD in diabetes. The definition of CKD in diabetes is the presence of an albumin-creatinine ratio greater than or equal to 2 and or an eGFR less than 60. Diabetic nephropathy is defined as progressive increase in proteinuria in people with long-standing diabetes, followed by declining function, which can eventually lead to end-stage renal disease. Diabetic nephropathy can be divided into stages based on the urinary albumin level. So starting at the far left, this is an individual with no urinary albumin, therefore considered to be normal, right up until an ACR of 2. Beyond an ACR of 2, they initially have microalbuminuria, and then when the ACR rises above 20, then that is then considered overt nephropathy. Now you can see at the area below the arrow that the urine dipstick is not a reliable test, given that by the time the urine dipstick is positive, the ACR is greater than 20. This table depicts the same information in terms of stages of diabetic nephropathy by level of urinary albumin based on urine dipstick, urine ACR, or a 24-hour urine collection. This table depicts the same information from the previous slide. Stages of CKD can also be defined based on the eGFR, and these are stages of CKD of all types, not just diabetic nephropathy. So stage 1 is when the eGFR is greater than 90. Stage 2 is 60 to 89. Stage 3A is 45 to 59. 3B is 30 to 44. Stage 4 is 15 to 29, and that is considered severe. And then stage 5 kidney disease is end-stage renal disease, defined as an eGFR below 15. So how should we screen for and diagnose CKD in diabetes? So let's take a closer look at this outline. Screen annually when no transient causes of albuminuria or low eGFR are present, and when acute kidney injury or non-diabetic kidney disease is not suspected. In type 1 diabetes, the screening should occur annually in postpubertal individuals with duration of diabetes greater than or equal to 5 years. And in type 2 diabetes, screening should occur at diagnosis and annually thereafter. And the screening should occur using a random urine albumin-creatinine ratio as well as a serum creatinine for the eGFR. But what does no transient causes of? So transient causes of albuminuria are listed here. Recent major exercise, urinary tract infection, febrile illness, decompensated congestive heart failure, menstruation, or acute severe elevations in blood glucose or blood pressure. So in the presence of any of these things, any albuminuria detected may in fact be transient and therefore needs to be repeated to ensure that this is in fact real kidney disease. So screening is to occur with a urine ACR and a serum creatinine. So if the eGFR is greater than 60 or the ACR is less than 2, then there is no evidence of chronic kidney disease and rescreening can occur in a year. If it turns out that the eGFR is less than or equal to 60 or the ACR is greater than or equal to 2, then the next step is to ask whether the random urine ACR is greater than 20. If it is in fact greater than 20, if however the random urine ACR is not greater than 20, i.e. it's less than 20, then it is reasonable to order a serum creatinine for eGFR in 3 months and perform 2 repeat random urine ACRs over the next 3 months. Then at 3 months, the question is whether the eGFR is repeated at less than or equal to 60 and whether or not 2 out of 3 out of the ACRs is still greater than 2. If that is not the case, then there is no evidence of chronic kidney disease and rescreening can occur in 1 year. However, if it is the case, then chronic kidney disease has been diagnosed. Now, after chronic kidney disease has been diagnosed, it would be relevant to order urine routine R&M and a urine dipstick. And the rationale there is to see whether there is any lab test suspicion of non-diabetic renal disease. So we need to be aware of the possibility of non-diabetes related causes of CKD, because as shown in this Venn diagram, people with diabetes can also develop CKD for other reasons, such as hypertension, renal vascular disease, or other kidney diseases. So when should we consider other causes of CKD? This table is an important one to remember because it outlines certain factors that may make you think of alternative diagnosis. So for example, if you look at the right side column, cases of extreme proteinuria with greater than 6 grams per day should make you think of an alternate renal diagnosis. Persistent hematuria, be it microscopic or macroscopic, or active urinary sediment, is also suspicious for another cause. Rapidly falling eGFR, reduced eGFR with little or no proteinuria should also make you think about other causes. Other complications of diabetes not being present or relatively not as severe should make you wonder if something else is contributing to the kidney disease. A known duration of diabetes of under 5 years should make you suspicious. A family history of non-diabetic renal diseases, such as polycystic kidney disease, or signs or symptoms of systemic disease associated with CKD of other causes should also make you think about non-diabetes related causes. So therefore, is there clinical or lab test suspicion of non-diabetic renal disease? And if the answer is yes, then the non-diabetic disease needs to be worked up or the patient needs to be referred. If no, Then CKD and diabetes is diagnosed, and the treatment guidelines can then be followed. Now, when thinking about the care that we're offering our patients living with diabetes, unfortunately, a care gap still exists in terms of screening. This is looking at the percentage of necessary tests to be done in individuals living with diabetes, and it turned out that only 74% of patients were getting urine albumin-creatinine ratios done. These data are a little bit older now, in 2009, so the hope and expectation is that the urinary albumin-creatinine ratio testing in individuals living with diabetes has in fact increased at this point. Prevention of chronic kidney disease and diabetes is possible, and it involves optimal glycemic control in both type 1 and type 2 diabetes, because these have been shown to reduce the development and the progression of nephropathy. In type 1 diabetes, we have the DCCT. The Diabetes Control and Complications Trial randomized people living with type 1 diabetes to either intensive glycemic control or more conventional control. These patients were followed for a number of years, and a number of complications were looked at, including, of course, renal. And as you can see on the left-hand panel, those who received intensive glycemic control had significantly less development of albuminuria. And on the right-hand panel, looking at secondary intervention, there was a 43% reduction in secondary progression of albuminuria as well. At the end of the DCCT trial, patients were told to get better glycemic control because we now know it's good for you, but then they were continued to be observed in the EDIC component of the DCCT. And in the EDIC component, over a number of years, and in this analysis depicted at 15 years, you can see that there continued to be improvements from an albuminuria perspective. A greater proportion of the originally intensively treated group returned to normal albuminuria, as shown on the left, and a lower proportion of the intensively treated group developed macroalbuminuria. Continued observations in the EDIC analysis is now extended to 25 years of published data looking from a renal outcome perspective. And there was a 50% reduction in the risk of impaired eGFR amongst those who were initially intensively treated. So now, not only is there evidence that better glycemic control will decrease the risk of developing microalbuminuria, there is also evidence to say that it decreases progression to macroalbuminuria, and then as well a reduction in the risk of developing impaired eGFR. What about in type 2 diabetes? So in the case of type 2 diabetes, we have the United Kingdom Prospective Diabetes Study, or UKPDS, which also analyzed the effects of tighter glycemic control on microvascular and macrovascular complications. The initial study was completed in 1997, and you can see that there was in fact a significant reduction in any diabetes-related endpoint and a significant reduction in microvascular disease. They also had an observation phase after the initial trial where everybody was told to get better glycemic control and were simply followed for an additional 10 years. And thankfully, all of the endpoints continue to diverge, meaning that the initially intensively treated group continued to benefit. And this also was true for microvascular disease, primarily driven by retinopathy and nephropathy. In the advanced study, they compared different levels of glycemic control amongst those living with type 2 diabetes using a sulfonylurea-based therapy or a non-sulfonylurea-based therapy. But what was noted in advance was a significant reduction in the development of nephropathy among those who had more intensive glycemic control. So we know that reducing the progression of diabetic nephropathy requires optimal glycemic control, as I've shown data for both type 1 and type 2 diabetes. But in addition, optimal blood pressure control and the use of ACE inhibitor or ARB is also useful for reducing progression of diabetic nephropathy. ACE inhibitor in type 1 diabetes with microalbuminuria reduces progression to clinical proteinuria, as can be seen in this older study using captopril. In addition, the use of ACE inhibitor also reduces macroalbuminuria renal outcomes. And as you can see here on the left-hand side, it is looking at percentage with doubling of baseline creatinine, which was reduced in those using captopril. And on the right-hand side, the percentage who died or needed dialysis or transplantation was also reduced amongst those using captopril. In the case of type 2 diabetes, we have good evidence for the angiotensin receptor blocker class. This is a study of irbesartan at the 150 milligram and 300 milligram dose, showing a distinct reduction in time to onset of diabetic nephropathy. In addition, this is a study of losartan, also showing reductions in renal outcomes in individuals living with type 2 diabetes with macroalbuminuria. And here, this is a study of irbesartan in the green, showing reductions in renal outcomes in those individuals with diabetes and macroalbuminuria. So therefore, the utility of the ACE inhibitor and the ARB class for reducing hard renal outcomes in individuals living with diabetes and nephropathy is quite well established. More recently, though, we are now beginning to see a different class of medications that are also showing very promising reductions in hard renal outcomes, and these are the SGLT2 inhibitors. So these are data looking at empagliflozin, an SGLT2 inhibitor, in the context of the EMPA-REG outcome study. In that study, about approximately 7,000 individuals with type 2 diabetes and pre-existing cardiovascular disease were randomized to receive empagliflozin or placebo. Now, EMPA-REG outcome was designed primarily as a cardiovascular outcome trial, but it was pre-specified to also collect data from a renal perspective. And what they found was that the use of empagliflozin reduced the doubling of serum creatinine, initiation of renal replacement therapy, or death due to renal disease by 46%. So remember, this is an anti-hyperglycemic therapy that has now been shown to reduce hard renal outcomes. It is not only empagliflozin that has shown these excellent data, but canagliflozin, another SGLT2 inhibitor, has also shown reductions in hard renal outcomes of about 40% amongst these individuals who were either secondary prevention cardiovascular or high-risk primary prevention. So now we have excellent glycemic control, blood pressure control, ACE inhibitor or ARB, and now we can add to the list SGLT2 inhibition to be beneficial factors to reduce the risk of developing and progressing diabetic nephropathy. However, we also need safe use of treatments in people living with kidney disease. So thinking about ACE inhibitors or ARBs, a practical tip is that a potassium and a creatinine should be checked at baseline and within 1 to 2 weeks of initiation or titration, and should also be assessed during acute illness if a patient is on an ACE inhibitor or an ARB. If the potassium becomes elevated or the creatinine is elevated by greater than 30%, then the therapy should be reviewed and the serum potassium and creatinine should be repeated. Mild to moderate stable hyperkalemia should be treated through counseling on a low potassium diet, and if remains persistent, consider adding non-potassium sparing diuretics and or oral sodium bicarbonate in those with metabolic acidosis. Consider temporarily holding or discontinuing ACE inhibitor, ARB, or direct renin inhibitor. In the case of severe hyperkalemia, hold or discontinue the ACE inhibitor, ARB, or direct renin inhibitor, and emergency management strategies should be implemented. Remember to counsel all patients about sick day medication list, namely SADMANS. S for sulfonylurea, A for ACE inhibitor, D for diuretics, M for metformin, A for ARB, N for non-steroidal anti-inflammatory, and S for SGLT2 inhibitors. These agents should be temporarily held in the context of acute dehydration or acute illness involving dehydration. And this is a handout that's available on the guidelines website, with the left-hand panel being designated for healthcare providers to remind us of what drugs to counsel them about, and the right-hand panel being a tear-off for the patients to remind them what drugs should be held in the context of acute illness. This is the updated figure looking at the antihyperglycemic agents and renal function. Across the top are the different stages of CKD, and along the sides are the different classes of medications as well as the individual medications. Dark green depicts that a dose adjustment is not required and the agent is safe to be utilized. Light green means that the agent is safe to be utilized, but a dose adjustment is required. Yellow means that caution should be exercised, but usually the agent can still be utilized. And red means an alternative agent should be selected. There is as well an appendix within the CPGs looking at therapeutic considerations for renal impairment with even greater detail. So when should a patient be referred? A patient should be referred in the context of chronic progressive loss of kidney function, an albumin-creatinine ratio that is persistently greater than 60, or an eGFR less than 30. In addition, a patient who is unable to remain on renal protective therapies due to adverse effects such as hyperkalemia or a greater than 30% increase in serum creatinine within 3 months of starting an ACE or an ARB. And finally, a patient who is unable to achieve target blood pressure should also be considered to be referred to a nephrologist or someone specializing in hypertension. For this chapter, the recommendations are as follows. Recommendation 1. To prevent the onset and delay the progression of CKD, people with diabetes should be treated to achieve optimal control of blood glucose and blood pressure. Recommendation 2. In adults with diabetes, screening for CKD should be conducted using a random urine ACR and a serum creatinine converted into an eGFR. Screening should commence at diagnosis of diabetes in individuals with type 2 and 5 years after diagnosis in adults with type 1 and repeated yearly. Recommendation 3. A diagnosis of CKD should be made in people with an eGFR less than 60 and or random urine ACR greater than or equal to 2 on at least 2 of 3 samples over a 3-month period. Recommendation 4. All people with diabetes and CKD should receive a comprehensive, multifaceted approach to reduce cardiovascular risk. Recommendation 5. Adults with diabetes and CKD with either hypertension or albuminuria should receive an ACE inhibitor or an ARB to delay progression of CKD. Recommendation 6. People with diabetes on an ACE inhibitor or an ARB should have their serum creatinine and potassium levels checked at baseline and within 1 to 2 weeks of initiation or titration of therapy and during times of acute illness. Number 7. Adults with diabetes and CKD should be given a sick day medication list that outlines which medication should be held during times of acute illness. Recommendation 8. Combination of agents that block the renin-angiotensin-aldosterone system, such as ACE inhibitor, ARB, or direct renin inhibitor, should not be used in the management of diabetes and CKD. Recommendation 9. People with diabetes should be referred to a specialist with expertise in CKD in the following situations: chronic progressive loss of kidney function, urine ACR persistently greater than 60, eGFR less than 30, unable to remain on renal protective therapies due to adverse effects such as hyperkalemia or a greater than 30% increase in serum creatinine within 3 months of starting an ACE inhibitor or ARB, or if they're unable to achieve target blood pressure. Recommendation 10. In adults with type 2 diabetes with clinical cardiovascular disease, in whom glycemic targets are not achieved with existing antihyperglycemic medications, and with an eGFR greater than 30, an SGLT2 inhibitor with proven renal benefit may be considered to reduce the risk of progression of nephropathy. Key messages for this chapter include: identification of CKD in people with diabetes requires screening for proteinuria as well as an assessment of serum creatinine converted into an estimated glomerular function rate. All individuals with CKD should be considered at high risk for CV events and should be treated to reduce these risks. The development and progression of renal damage in diabetes can be reduced and slowed through intensive glycemic control and optimization of blood pressure. Progression of CKD in diabetes can also be slowed through the use of medications that disrupt the renin-angiotensin-aldosterone system. Key messages for people living with diabetes. The earlier that the signs and symptoms of chronic kidney disease and diabetes are detected, the better, as it will reduce the chance of progression to advanced kidney disease and the need for dialysis or transplant. You should have your blood and urine tested annually for early signs of chronic kidney disease and diabetes. If you are found to have signs of chronic kidney disease and diabetes, your healthcare provider may prescribe medication to delay more damage to your kidneys. For more information on this chapter and others, please visit guidelines.diabetes.ca or download the app from Google Play or the App Store. Thank you very much for your attention.